said, I want to just quickly thank all of the sponsors here on this slide that are sponsoring all of this weekend's conference sessions. And now I want to introduce OIF Board of Directors member, Mike Sheridan. Mike, thank you.
Yeah, hi everyone. My name is Mike Sheridan. I've been on the board for about a year. I have a daughter who's 9 years old and had some dental issues. She has type 3-4, and so we're kind of been learning as we go the last 9 years. But the first speaker is Dr. Kevin Ricker, who is a pediatric dentist at the Chatham Pediatric Dentistry in Chapel Hill. He previously worked as a high school teacher and pivoted into dentistry because he has OI and understands the OI dental complications firsthand. Next, we have Dr. Joseph Napoli, who is a member of the Division of Plastic Surgery at Children's Hospital in Philadelphia and is a faculty member at Pearl School of Medicine at the University of Pennsylvania. He is also an author and expert in multiple craniofacial abnormalities. And last but not least, we have Dr. Jean-Marc Retrouvey, who is a Leo Rogers Endowed Chair at the Orthopedic Department at the University of Missouri in Kansas City. He is also a medical advisory council for the OIF and is the principal investigator for the Brittle Bone Disorders Consortium study, which is titled Dental Malocclusion and Craniofacial Development in OI, which has been just renewed for a second phase. With that, I'll just take it back to you.
Well, hello, everybody. Give me just a second to turn on my my slides here. Let's see. Let's see. All right, there I am. So thanks for having me back. I think this is the third round that I've done, once in person and then once after the world ended. So thank you so much for coming. And I'm going to focus on kind of Dentistry 101 for people with and without OI. And I'm just going to go through some very basic information because the way that I kind of get the pulse of what's going on in the OI community with regard to teeth is I sit in the secretest corners of that Facebook group and I wait for the questions to pop up. And then I see both what kind of answers other folks give and then how many of them are totally out of left field and how many of them are incredibly astute and like absolutely right on. So forgive me, but I'm going to run through just how teeth work 101, and then I'm going to talk a little bit about things you can do going forward. I've titled it Managing the Bottom Third of Your Child's Face, your face too, but my specialty is pediatric dentistry. So I'm going to start running through. So basic stuff. First of all, OI versus dentinogenesis imperfecta. So OI is specifically a problem with making connective tissue, either from not enough collagen or the wrong kind of collagen. Your genes don't quite build all the structures correctly. And it can occur with troublesome teeth or without troublesome teeth. Dentinogenesis imperfecta is specifically a problem making dentin, which is the middle part of the tooth. And I'll show you what I mean when I say middle part of the tooth. And it can occur with or without OI. Your teeth can be discolored or they can be weak, or most likely both. So when I say the middle layer of the tooth, I'm talking about the dentin. The thickest part of the tooth is made of dentin. And if you are a person that has OI and has brittle teeth, that means that that part of the tooth is the part where the problem is, okay? And it's kind of the bulk of the tooth. And studies have shown that half the people with OI report problems with their teeth, even if they formally haven't been diagnosed with DI. And I would wager that it's way higher than that based on personal experience and talking to folks at these conferences. Why is it a problem? Well, when the dentin is too soft, the enamel on the outside of the tooth, which glues to the dentin, and the enamel is the important protective layer that makes your teeth functional, it breaks off because it's not glued to the sound substrate. And once the enamel is gone, that tooth isn't strong enough to fight either regular tooth decay or the wear that comes with chewing or just breaking like your bones. So I took these pictures from a mentor of mine, Tim Wright at UNC, and this shows a couple of things. On the picture on your left, you can see what untreated teeth with DI can look like. And you see they are discolored, and you'll see 3 teeth that are kind of bright white. And those teeth were treated early on by covering them up with plastic filling material. Now, over time, after a while, that the patient came in for those treatments, disappeared, and then reappeared. And when they came back, you could get a really nice look at how everything was going in their mouth. And so you can see both affected teeth, and you see that they're yellow, and you can see that parts are worn off, and kind of what a general appearance of this looks like, give or take, maybe a 3-year-old. Okay. These are some x-rays of some grown-up teeth that were affected by Guy. And just, this is more for taking a look at more than anything else. We won't get into all the clinical specifics of what a DI tooth looks like versus a healthy tooth, but some things to look at. You can see, and I don't know if I can get my pointer to show up there or not. I don't know how to do that. Maybe right about here. You can see that the rest of these teeth are kind of around it have these nice bumps and everything, but right around here, it looks all kind of crumbly and bumpy. And that's just where the enamel that couldn't hold on to that tooth just fell off. And that happens sometimes when you have the kinds of teeth that have weak dentin underneath. Oh my gosh, now how do I get rid of that? That's an even better question. Forgive me, guys. Let's see. There we go. Thanks. I gotta get rid of my annotation menu. In terms of what are your goals as a patient who either has OI or has a kid that has OI and they have teeth and a face, right? Which is most of us, at least to start. Your goal should be to keep the teeth as healthy as you can from the beginning. So you want to avoid cavities just like everybody else. You want to protect your teeth against them breaking just like everyone else. You want to make sure that as you grow, as your body grows and changes, like from the time when you're small to the time you get a grown-up face, and then as you get kind of an older person's face, that you're managing all of those parts smart. And you want to avoid any social problems that come up with having teeth that may not look or work like everyone else's. So for the first step, it's the most straightforward, and you can get this information from any dentist, although seemingly they don't always tell it to you. You want to avoid cavities. So the way that you do this is by drinking water. That's the first thing you can do. You're reducing your risk by decreasing how often you hit your teeth with sugar. Water makes your teeth stronger, not weaker. Everything else makes your teeth weaker. Milk makes your teeth weaker. Juice makes your teeth weaker. Sweet tea, because I live in North Carolina, makes your teeth weaker. Everything you can drink other than water affects your teeth negatively. You want to avoid sticky, sugary things that sit on your teeth for a long time. Not just things like gummy bears, but even dried fruit, fruit snacks, granola bars, raisins, craisins, anything that sticks into the grooves of your teeth, and then you have to clean those grooves out with your tongue. Try to avoid those. Then you want to keep your teeth clean. You want to scrub all the bacteria that grows on them off every day, twice a day at least, and you want to use fluoride toothpaste because fluoride makes your teeth harder. And then at least once a day, get in there and floss like you mean it. And in my experience, the OI population is not a whole lot better than the general population at actually getting in there and flossing. But whereas somebody else might be able to get away with it, we probably cannot. When it comes to your kids, you should not trust a kid to brush their own teeth until you can trust them to go take a bath and really scrub out all of their crevices. Until they can do that, or if their limbs are not long enough or those kinds of things to have sufficient dexterity to get in there and get themselves clean, you can't say they brush their teeth because most of them can't do it well. In terms of avoiding tooth fracture, you don't want to bite on anything harder than your teeth. And sometimes that sounds very straightforward and easy, but I'm going to guarantee you many of the people watching this presentation have done exactly this. They were chewing on an ice cube. They left some M&Ms in the fridge, and they took one bite just wrong and split a cusp off a tooth or broke a tooth down the middle. And I say that because I have done that more than once. So that's coming directly from experience. And then if your teeth start to wear down, you want to get them protected as early as possible by covering the whole tooth with a crown. And any dentist in the world can do a crown on your tooth. What that does is covers the whole thing and protects it against future problems. A filling just removes the diseased or broken part and replaces that usually with plastic or metal. A crown instead covers the whole thing up and gives it a kind of a protective coat that's harder to break. Generally speaking, crowns for folks with OI and DI are more predictable in the long term than fillings are. The earlier you get a tooth protected, the more likely the tooth is to make it all the way through to the end of your life. In terms of monitoring your growth, everybody grows up, even pediatric dentists. Okay, some of us with OI don't physically grow a whole lot taller, but we still continue to grow up, which means that you want to be able to eat whatever you want to eat when you are an old person. Once you're 142, you want to eat anything you want to eat. So you need to have the strongest possible set of teeth that you can. So you want to make these teeth survive. And if you end up losing those teeth early, there can be growth and development consequences to that. And Dr. Retrouvey will talk about that a little bit when we get to him. And children with OI, as Dr. Retrouvey knows all too well, are more prone to having problems with the arrangement of their top and bottom jaws relative to both their skull and to each other, and then the subsequent problems with their bite. And all of that just means you got to watch it closely. We want to make sure that we address social problems. People are routinely judged by their teeth. The earlier you get a teeth fixed or your teeth fixed, the less social problems you are potentially setting yourself up for by being concerned about them. In terms of finding a dentist who will treat you, and this is often a big challenge for OI/DI folks, you want to try to find someone generally who has had a little more training than dental school. You want to find maybe the nearest dental school. There are, I think, close to 60 dental schools now scattered across the United States. And of course, there are a lot more internationally since we're translating today. And generally speaking, the closer you get to an academic dental center, the more comfort folks are going to have on folks with rare conditions. You can also ask your physician where their other OI patients get their dental care if you happen to live in a place where that's more common. And then you want to make sure that your child already seen a dentist by the time they hit their first birthday. But you got to remember that OI is a rare disorder. That means it's hard to find someone in the general population that has had a lot of experience treating patients. What you want to do instead is find someone who is comfortable listening to you and coming up with clever solutions to complex problems. I think it was Dr. Raggio was talking about this in the mild OI forum. You're not going to find a lot of people who treated OI, but you can find people that are smart and fundamentally understand biomedical science. And once they grow up and they need an adult dentist, same guidelines apply. You're going to consider maybe seeing a prosthodontist who's a specialist in complex restorative adult dentistry, maybe to be the quarterback, because you're still going to need somebody to do root canals. You still might need somebody to do braces. You still might need somebody to do tooth extractions and jaw surgeries. You still may need someone to do crowns and bridges and dentures. But the prosthodontist is really good at coordinating all of those things together for maximum patient benefit. And with that, I'm going to stop because we're trying to shorten these and give you guys more in time for Q&A this year. Okay. Thanks.
Dr. Ricker, thank you so much. Now I'd like to introduce Dr. Joseph Napoli, who will be speaking next.
Thank you very much, Michael. And it's always interesting following Dr. Ricker because it's generally a hard act to follow, but I'll do my best. So today I'm going to speak about some of the maxillofacial surgery considerations in OI, and really going to just focus on two of them. There are a lot of issues that occur in the maxillofacial region, but we're going to just focus on two things today. One of them is malocclusion, and really I'm going to talk about the surgical care of malocclusion. Dr. Retrouvey later will give you more detailed information about orthodontic management. And the second thing I'm going to mention is a discussion on how to manage missing teeth. And it's nice to follow Dr. Ricker on this because he gave a great segue into this and how important it is to prevent the loss of teeth. Now, why are these two things, malocclusion and missing teeth, important? They're important because they have both functional and aesthetic ramifications.
Dr. Napoli, can I interrupt you? Do you mean to be sharing slides right now?
Yes, can you see it? I hit the screen share.
We actually cannot see the slides. We see you, but not the slides.
Okay, so let's go back to, let's see, we haven't missed too much. So I'll do the screen share now. How's that? Can you see them now?
That looks good. Yeah, we see it
Okay,
layout view.
right. So the first slide was just the introduction and you didn't miss much. Here we go.
Perfect. Thank you.
Okay, so the reason it's important, these issues are important, is because they have both aesthetic ramifications and functional. And Dr. Ricker spoke earlier about the social consequences of problems with the teeth and the occlusion, and also there are functional issues as well. And these go hand in hand. What are some of the functional problems? Well, obviously, the one that most people are aware of is eating. If the teeth are missing or if the teeth are not lined up, there's going to be trouble biting into your food as well as chewing. There's also a problem. There could also be problems with speech, which is not really obvious at the get-go, but the way the teeth line up could directly influence the sounds that come out when one is speaking. Now, less commonly, there could be breathing problems when the jaws are not lined up properly, but this is mainly a problem when there is a very, very severe malocclusion, where maybe the upper jaw is much too small to allow air to pass through the nose. But this is pretty uncommon, so we're not going to address this today. So let's just talk about let's see, I can't advance the slides right now. Let's try that. There we go. Okay, so the first thing we're going to talk about is the malocclusion. Now, malocclusion essentially means that the jaws and the teeth are not lined up properly. And like anything else in life, you can have a problem that's mild or moderate to one that's very severe. The young boy on the left would have a malocclusion that's sort of moderate. In other words, the teeth aren't lined up, and trying to fix this orthodontically may not give the best aesthetic results. So he might be a candidate for jaw surgery to move the jaws into a better position. And incidentally, he's not a patient with OI. Now, if you look at the patient on the right of your screen, that would be considered a severe malocclusion, where the front teeth are not even close to the bottom teeth in the front. And so you could see that she would have a difficult time biting through her food. So in the mild to moderate forms of malocclusion, there's a type of surgery called orthognathic surgery. And orthognathic means alignment of the jaws. So this is surgery that's designed to move the jaws into a better position so they line up properly. And this is the conventional way to treat a malocclusion that cannot be treated with braces alone. So you can see the picture on the left, you can see that he has a bite where the teeth are not lined up properly. And on the right side, you can see the jaws have been moved into better alignment. And it also has a positive effect on the contour of his face in profile. So that would be conventional orthognathic surgery. But there are times when the bite is so severe that you can't just move the jaw in one go into the right position. And in a situation like this, we would consider doing a staged procedure where you might treat one jaw first, allow it to heal, and then a second procedure to do the other jaw. And in this particular patient, we used a technique that I think is a very good one to use in severe malocclusion called distraction osteogenesis. And I'll explain what that means in a second. So in distraction osteogenesis, instead of cutting the bone and moving it to its new position, the way this is done is the bone is cut and metal devices, as you can see here on the slide on the right, a metal device is put on the bone that allows the family or their doctor to slowly advance the bone into its new position. And if it's done properly, if it's done slow enough, as the bone is moving, new bone will grow in and fill in that gap. And one of the big advantages of this is when you move the bone to the new position, you don't need to take bone from another part of the body to fill in the gap. The bone will grow on its own. And so in this particular patient. The upper jaw was treated first. It was moved into the position that we thought would be best for her in terms of aesthetics and occlusion. And then we did a second operation to set the lower jaw back to meet the upper jaw. And in the picture on the top right, you can see all this new bone that has grown in to fill in the gap. And you can see a better alignment of her teeth. And on the bottom two pictures, it's the before and after X-ray of the jaw alignment. And these are just pictures to show the aesthetic result. She had a functional improvement in that she was able to chew and eat her food better, but also aesthetically, she had better balance after the upper jaw was moved forward and the lower jaw was moved back. Now, someone asked a question earlier about Invisalign, and her orthodontic preparation was in fact done with Invisalign, and I think Dr. Retrouvey will probably speak more to that later. So let's change gears now and talk about missing teeth. I think this is probably a topic that has generated a great deal of interest in patients with and without OI, because the way missing teeth are managed now is very different than they were managed 30 years ago. And the technology has actually improved a great deal over the past 10 to 15 years. So missing teeth can either be congenital, in other words, people can be born without the full complement of teeth, or missing teeth can be because the teeth were extracted. So that would be acquired, an acquired problem. And hopefully with some of the information Dr. Ricker provided earlier, this would be a less common problem. But in any case, it does happen. People end up having to have teeth extracted for various reasons, and they need to be replaced in many cases. So the conventional ways to replace missing teeth fall into really three categories. One of them is if there's a missing tooth or missing teeth, dentures can be made, either a full denture or a partial denture, which is a prosthesis that the patient has to put in and take out to clean it. And sometimes they're not comfortable. And removable prostheses, in general, they can work well, but sometimes they could cause injury to the surrounding teeth. Then the other option is something that the patient doesn't have to remove, and that would be with crown and bridge work. So the picture on the right is an example of a crown of a bridge. So you can see where the arrow's pointing here, there's a missing tooth. But to make a bridge, it requires that the dentist file down the tooth in front of the missing tooth and behind the missing tooth so that they can fit a bridge, which is a crown on each of the filed down teeth that holds a false tooth in between. That's called the pontic or the prosthesis. And this is cemented or glued to the teeth. Now, the major disadvantage of this is that it requires taking two teeth adjacent to the missing tooth and doing some work on them to allow this to fit. There's a lot of excitement about implants, though, because implants allow the dentist to actually just replace the missing tooth or missing teeth without necessarily filing down the teeth adjacent to the tooth gap. So the way it's done is very, very carefully. A hole is drilled in the bone, and this first picture shows that happening. And it's got to be done very precisely without damaging the surrounding bone. And once this precise hole is drilled, an implant that fits that hole exactly is screwed into the bone itself. And once that heals and the bone heals around the implant, the dentist could then come into another stage and add the tooth or the prosthetic tooth, screw that directly into the implant. And that leaves the teeth on either side of the missing tooth untouched. So this has really taken off in terms of ways to replace missing teeth. And if someone has had all of their teeth removed, you can still get implants. It's not practical or cost effective to replace every single tooth, but if a few implants are placed in each jaw, then a denture can be attached to those implants. Now, the question is, what is the success rate in patients with OI? There's not a lot of experience or a lot of data on this, but when I reviewed the literature, the theme is this. In patients with very mild OR, say type 1, the success rate is greater than 90%, which is about the same as it is in patients who do not have OI. Now, when we're talking about more severe forms of OI, say type 3 and 4, the literature has wide variation in the success rate, from less than 50% to greater than 90% at 5 years. And it's really hard right now to ferret out, what the reasons for the discrepancy are. Placing dental implants is very technique sensitive. And if it's not done properly, even in patients without OI, the implants may not take. They may loosen up and then need to be removed. So my recommendation would be whoever is going to place the implants, they should have a lot of experience with implants in the general population and also be knowledgeable about OI and work with the patient's physicians who are doing the medical management, and work very closely with them during the surgical process. Now, this next slide shows what are some of the risks of placing implants and how you might be able to mitigate or reduce those risks. The risks: poor healing. That's generally if the implants are not kept clean when they're put in, or if the technique didn't allow the bone to heal properly, and the implants can loosen up. It'd be very rare, but a bone could fracture. Even in someone without OI, there could be a fracture if the implants are not put in properly. How would one reduce the risk? Well, we know that smoking delays healing. So anything that one could do to stop smoking prior to surgery would help. Meticulous oral hygiene. We want to limit the amount of bacteria that are in the area. So most of the time after an implant is placed, the surgeon would prescribe a mouthwash, an antibacterial mouthwash. And then, of course, the surgical team expertise. And then finally, the role of bisphosphonates. This is a pretty big topic, and wouldn't have enough time to go into this, but suffice it to say that the surgeon should work very closely with the internist who's managing the OI to discuss timing of bisphosphonate and how long someone might need to be off it before the surgery is undertaken. So just one more example about showing a patient who had multiple implants placed for a partial denture. This patient did not have OI, but I'm just using it as an example to show what can be done. She had a large section of her jaw removed because of a tumor. So she lost all the teeth between this molar and the premolars on the other side. So once the bone graft was placed and healed, she had 5 implants placed, and on those implants was attached a partial fixed denture, which could be removed by the dentist to clean it, but generally that only happens maybe 2 or 3 times a year. And that just brings me to one more topic. There are some patients who might not have enough bone to place an implant. It doesn't mean they're not a candidate for an implant, because one can have a bone graft placed, and it might just be a small bone graft, which would be just big enough to allow the surgeon to place an implant into it. So I'm very excited about what can be done for missing teeth. And it's not something I do on a regular basis, but there are many, many well-qualified and trained surgeons who might be able to do this type of work. And that's all I have. I think I got in within 10 minutes.
Excellent. Thank you so much, Dr. Napoli. That was fantastic. So up next, I would like to introduce again Dr. Jean-Marc Retrouvey, who will be speaking next. Dr. Retrouvey, can you hear me?
Yes.
Okay.
But I don't see myself on the screen. That's why I was a bit confused. But that's okay. Maybe it's okay. Can you see my screen?
It says it's loading now.
Okay. Is that okay?
I am seeing, it says, oh, yes, now I can see it.
That's
Dental
all.
care and malocclusion and OI.
Yeah, that's it.
Perfect. Thank you.
So I was very, as usual, impressed, and I always enjoy listening to Dr. Napoli and Kevin Rickler. So it's always interesting. Are you okay? Can you listen and everybody hear as well? Because I got two computers working. So basically, I'm going to finish off. That's one of our patients here. She's a little cute OI patient of us. And let's see what we can do. So again, two of my patients who are actually have been treated. This lady was from Canada. This is from Quebec, and he has my braces on. So left side is OI type 1. Right side, I think, is OI type 5. And that's the look of the occlusion of an OI type 5 on OI type 3 and 4 on the middle here, which is an intraoral scanning machine, which we use for our OI population. So you can see there are some gaps here, and the occlusion is not really perfect, as Dr. Richter and Napoli were mentioning. And really what happens is you have to see that, again, that's an OI type 1, one of my patients, that's an OI type 4, one of my patient 2, and another one here that would require orthognathic surgery. You see the chin is very much overdeveloped and the upper jaw is not. And you have a type 3 patient there. Which are the most common when we talk about OI? We talk about these 4 types or 3 types of OI, because type 2 is not discussed. And you have type 5s, again, that's a patient from Florida I've been helping treating. She will get orthognathic surgery. This lady is a type 6. She never had braces. You see, type 6 does not affect the occlusion as much as the other types. 7 is mainly in Quebec, affects a native population, so that's an unusual type. And you have other ones. So these are more rare types that can also benefit from orthodontics. But basically, we'll talk more about the type 3s and the type 4s today. So the big characteristics, and again, that's one of our patients. You can see the dentition right here. You can see also that these patients have some significant alterations of their profile due to the fact that the bones are not really well positioned. You can also see that we look at the transverse possibilities, and you can see the big distance between the upper and the lower jaw. So this makes our treatment pretty complicated to achieve, because a lot of these patients require orthognathic surgery or Dr. Napoli services when the malocclusion is too severe. So something I wanted also to show is we take a lot of these 3D X-rays nowadays to do some, I would say, manipulation, but that's an interesting finding that I had one day is these patients here present a different type of occlusion, where actually this patient now has the upper teeth are there and the lower teeth are here. So she does not present the typical aspect of an OI type 3 malocclusion. So you can find all sorts of different expressions of the malocclusion in the OI population. But usually this is what you see, where the back teeth do not touch. And that's a significant problem, because it's very hard in orthodontics to do this vertical manipulation and bring the back teeth together. And what happens too is you also have some teeth that are impacted, meaning they are not coming in, they will not come in. Here it's harder for you to see, but these are baby teeth, and this patient does not have any adult teeth under, so we have some lack of teeth to be dealt with. And again, maybe maybe implants, maybe other treatments. And you have the two upper teeth are touching the lowers, which they should be over. So these malocclusions are typical of the I would say OI type 4 and 3 population. You see again the big gaps, no adult teeth. These are caps that have been placed on the teeth, and you see one little tooth right there. So this tooth is slowly forming. It should be more developed. And this tooth now is growing at a wrong angle, and this is a baby tooth falling off. So all these x-rays allow us to really see and modify, or actually quantify, I should say, the malocclusions in 3 planes of space. And it has been a very good adjunct to our, I would say, diagnostic power on OI population. Here is an interesting study we've done about airway. I was listening to Dr. Napoli talk about breathing and in OI, and something that we found because of the scoliosis, and I will listen to Dr. Shah on Wednesday actually, because it's going to be very interesting. There is also the junction between the vertebrae and the cranial base, I call this basion, which is the term. What happens in OI patients, sometimes this long bone here can go into the cranium and cause central sleep apnea. So I would urge you to make sure that your children or even yourself does not present this problem, because it's called central sleep apnea. It's different from obstructive sleep apnea, where the airway or the air pipe is blocked. It's totally different, and it's very, very also fairly dangerous. So that's important, because that's a finding we see more often in the OI population than in the non-affected population. Can you do fractures? Yes. This patient called me one day, says, my jaw is kind of loose. She had braces. You see the wire here to hold the teeth after braces. She was fine. And one day she had this tooth extracted, which is a wisdom tooth. And all of a sudden she had a fracture of the jaw right here. So the treatment was to do nothing. We put on soft diet, and she healed up, I would say normally, a little bit slower, I think, but interestingly enough, this tends to, and I'm not sure, affect OI population more often. So if you have an extraction of wisdom teeth to be done, please see someone who has a lot of experience. There are different ways to extract these teeth, and they should be done atraumatically as much as possible. Another patient of mine called me. She's a sweet little patient, Catherine, and she says to me, I bit on something and my jaw cracked. And I said, oh, you cracked your jaw? I thought it was the joint here that made a sound. He said, no, my jaw cracked. And I said, are you sure? He said, yes. That's all I did. I bit on something and my jaw cracked. So we sent her to a hospital in Quebec City, and you can see the fractures right here. So I thought that OI patients, for whatever reason, did not present fractures of the jaw, unlike the long bones. But I was wrong. We had, in 1 year, we had over 3 or 4 fractures. So usually these fractures are not surgically addressed. Usually, and again, Dr. Napoli could talk more about it, we usually let them on soft food, and they tend to heal without complications. But it's painful, and you have to be careful. So that's unfortunate sometimes. The lower jaw will fracture also, like any other bone. So I was going to introduce my new project, which is called the use of aligners for the treatment of moderate malocclusions in a OI population. And what it is basically we call it Invisalign. I think the company is Invisalign, I think, at the moment. And what we're going to try to do is see if applying aligners to malocclusions of moderate amplitude in an OI population can result in better function, better aesthetics, and we will quantify it. It's a first prospective study, meaning that we are going to be starting it's not retrospective, it's not looking at results from other times, it's looking at the future. So we'll start with patients, or subject, I should say, that fit the criteria, and we will provide the care and monitor the care. So it should give us a whole lot more information in the next 5 years of what can and cannot be done. So that's, again, I showed that my favorite patient, type 4 male patient that only has one tooth touching right here. Can you see that? Only one tooth. That's all he has. He's got this significantly, open bite. But again, the problem that, and we became friends with him. It was interesting when he told me, and I said, you must have problems eating. And he said, no. I said, oh, that's strange. And then we treated him, and I'll let you know, and then I'll give you the punchline. So we had over 12 millimeters of open bite to close. We suggested orthognathic surgery, but the mother did not want orthognathic surgery. You can see that the upper jaw is much smaller, or less narrow, I should say, than the lower jaw, which is exactly the reverse. So that's a typical OI malocclusion. He also has, as Dr. Richter was saying, he has DI. And you can see also that this tooth here is a lot less affected than this tooth right here. So we have a study that found that a lot of DI is actually tooth dependent. Some teeth are much more affected, but we have no time to discuss about that. So it's not a problem of the whole dentition all the time. Some patients will present with more DI in the lower arch. Some people will present more DI in the upper. So it's very variable. And it looks like as you can see, this patient has DI, but doesn't show any fractures. So again, it's unpredictable. So we treated this patient with Invisalign, as you can see here. Very good patient. He wears elastics really nicely, and slowly but surely he closed up. Obviously, we did not correct the crossbite. We did not touch this tooth because it had a very strange root. I didn't want to touch it. But the funny thing was, one night he woke up his mother and he said, "Oh, Mom," he says, "I just noticed something. I can chew now." Because then I asked him, I said, "Why did you never told us that?" Because I never chewed in my life, so I didn't know what it felt like, which was very interesting. So he was very happy, and all these little piece of metal you see on the teeth are just handle for me to use elastics to bring the teeth together. And he had a very good response, and I kept on moving them around. He was always asking me, "So what are you going to do today?" So I put little things here, and I put them here, and then I took them off. I put them here, depending on what I was seeing at the visits. I would change the little buttons, and I was not afraid to break the teeth because they were pretty solid. And on top of these buttons are not very, very solid, so they're very simple and easy to remove. So that was our treatment. That was our first patient that we did as a prospective patient that gave me the idea of doing Invisalign on our population. And I've been helping quite a few people all over the world, and mainly North America, to treat patients with OI/DI and with malocclusions. And we had some good success. I don't know what I'm doing here. Okay. So that's our little research project, or big, whatever, depend what you do. We have three centers. We'll have the East Coast, the West Coast, and I'm from the Midwest, so I'm in the middle. We'll have West Coast, East Coast, Midwest, so we'll have 3 centers. We are definitely looking for people who are interested. Eventually, the problem we have is we want to avoid long distance traveling, so we'll see what we can do. But this study will hopefully help our population get better aesthetics, better function. But we cannot treat everybody. It has to be a moderate malocclusion. And whenever we get to be better, maybe we'll tackle the more complex cases that Dr. Napoli was showing in the future, hopefully, with a prosthodontist, and get even to a higher level. But at the moment, we are doing the moderately affected OI subjects only. And if you want to have more information, you can send an email to Suzanne, my wife. She's our coordinator, and she will be more than happy to give you information. So this one is an interesting one too. It's a small little lady from Florida. And the gentleman called me and he said, "I don't know what to do because this little lady is only 7 years old, and we need to be getting, the palate is very, very, very small. Even the incisors that you can see here, they can't even erupt. There is zero space for the second set of teeth that will come here." And I said, "What can we do?" Because she has fairly severe the eye, but not super severe, but severe enough, and severe OI, sorry. And he can't even put a band. You see the gingiva is going over this tooth, and he says, what can I do? I've been waiting for a long time to, and this happens often because the teeth in OI subject tend to erupt a bit slower. So what I did, I made in an Invisalign expander, which is very rare. It's actually a homemade, it's not an Invisalign expander, it's my home device. And what we did, we used plastic overlay dentures, fully transparent, and there are a sequence of them, and we keep on changing them. And that was the first set. I have the second set to show you one day. Well, it became even wider. So we got 5 millimeters, which is 2/10 of an inch of width increase. And you can see the space now is opening right here. So we have some spacing. We are, you can see that. We also are pushing the teeth forward and turning them. So now the patient is doing really well. And the last set I got was even better. So we don't know the limit of this technology, but I think it's age dependent. The younger, the better. And that's her, that's the contraption I was doing. You can see the little attachments, pieces of plastic I bonded on the teeth. And this actually, I shouldn't say I bonded, I suggested to bond. The orthodontist is actually in Florida and performed the work. And he keeps on sending me pictures and we have a good relationship. And this little kid is super nice and she's doing a great job. And you can see how small the jaw was. You know, it's like from 13 to 17, it's very, very small. This should be, normally it should be 42 millimeters and she has about, I don't know, not that much, 24. So she's very, very, very deficient. So we'll hope to get her to 30, 32, hopefully when she ages and she'll have a chance to have all the teeth in the mouth, or at least a fair amount. So I want to thank the OIF for the kind invitation and I'm done. And oh, by the way, I was also pretty proud that one of my students, this is the Journal of the American Dental Association, sorry about the poor picture. And we were able to make the cover page of this magazine or paper, the journal in the spring of 2020. So OI was on the cover. I was pretty happy. It was a great piece of work. I was just supervising and I'm pretty proud of this person. So after, I am pretty much done, Michael. I'm ready for questions.
Dr. Retrouvey, thank you so much. You are such a resource for our community, and we're so thankful to have you. So I want to thank all of our speakers today who joined us, and also to everyone in the chat. We have lots of audience questions, lots of back and forth and discussion, very dynamic. Thank you so much. So we're going to just jump straight in. So I want to start off with some questions. Specifically, we're getting lots of questions in the chat about crowns, and we'll start there. So some people are asking about, for those who have been told that crowns are not a viable option and that they fall out frequently, do any of you think that then veneers are the next logical choice for people with OI?
No, I'd be glad to take that one.
Great. I'll put my grain of salt after.
So they're really two different things. So a crown covers up your entire tooth. A crown, a veneer, you think of almost as a fraction of a crown that covers only kind of the aesthetic surfaces of the teeth to make them look better. If you're not a great candidate for crowns, you may or may not be a great candidate for veneers either. If you're not a great candidate for a crown to stay on your tooth, there's not a ton of great restorative options beyond that. It may be time to think about getting that tooth taken out and replaced with an implant or a bridge or a prosthesis of some kind. A crown is kind of one of our last ditch and most definitive treatments for teeth.
Well, all I was going to add exactly the same thing. I was a dentist for 10 years before I became an orthodontist. I did a ton of crowns, and I'm actually for the OI population. I think going back to the future is better. That people want to have full porcelain crowns, but they're not really covering the teeth as best as, let's say, a metal or even a gold crown. And Dr. Richter is saying the same thing. Yeah, that's exactly it. So if you want to have better crowns, you need, it's like a lobster. You need the exoskeleton.
Right.
And the exoskeleton, which would be the crown, has to really englobe the crown and help the crown. So I would argue for back teeth, the gold is way better. It's still the best material. For the front, it's a bit more complicated. So that's all I was going to say is you need to still have enough root foundation for the crown. And if you do, I think having something that is very snug on the tooth is better than on the tooth. Otherwise, you may fracture again and it's a waste of time.
And another reason to support a all crown on a back tooth is that you have to take away less healthy tooth to put it on there than you do for an all ceramic, particularly for OI folks, where you really want to try to avoid having to get a root canal if you don't have to.
Got it, thank you. Sort of like on that same note, someone was asking about saying that they have broken their teeth horizontally so that crowns don't always offer the best protection. And do you have any recommendations for those people that want to avoid this horizontal breaking along the gum line?
Again, I would jump in. Usually, if you're going to break a crown off at the gum line, it's either because your tooth was literally so incredibly weak that it couldn't withstand the lateral forces of biting, or because you got fresh tooth decay down on that edge between the crown and the tooth that undermined it. And of course, I have no idea. I haven't seen this person's tooth. It's comparatively uncommon to break a tooth that way, but it of course can certainly happen. And I would argue that if you're in the state where you're breaking teeth horizontally, you need to get someone to look at your bite and make sure that all of the parts are kind of working correctly in terms of the way your teeth fit together, top and bottom, front to back, side to side. Or again, maybe your teeth are so affected that you might not be a great candidate to keep your teeth. I mean, I don't know, Dr. Retrouvey may have a different opinion.
Well, no, it's just exactly the same thing. The problem is I've seen so many OI patients that a lot of them have very poor bites and 3 or 4 teeth are touching. Only you put a crown on one, it's taking a ton of pressure and it will break. So yes, absolutely. Even on non-affected patients, we tend to try to get as many teeth to touch, even if the occlusion is not perfect. Try to get as many to touch first before you put a crown on one. And as I always say, also, if one tooth is really, really bad, why don't you have it removed and then try to invest your money in the other ones? We tend to overemphasize the ones with very poor prognosis. And then what happens is slowly, it's very frustrating. You lose all your teeth one by one, and it's really, really bad. So as Dr. Richter said so well, go see a prosthodontist. He's going to make a full evaluation and say, okay, invest on these, don't invest on these ones. A general dentist may do it tooth by tooth, and by the time you finish, you end up with no teeth because you spent a ton of money and you lost your teeth anyways.
The other part that I would say regarding the prosthodontist getting involved in kind of like which teeth are the most strategic is the thing that prosthodontists get a lot of extra training in that a lot of general dentists get shorted on is that vertical component of your bite. And that's really so critical with OI patients, like Retrouvey was showing you with his pictures, where a lot of folks with OI kind of have what looks like a little bit of a shorter face. And you want to make sure that as you maneuver all these pieces around, that you don't skip measuring and keeping track of that vertical dimension.
Great, thank you. I'm going to ask another question, but then I'm going to leave a little bit early, and my colleague Jess Ransom will continue the Q&A. I just want to let everyone know that. So we have another question here that's asking about deviated septums. Is it safe for people with OI to have deviated septums fixed? And are there any special considerations for that? I believe, Dr. Napoli, this may be for you.
Yeah, so there's a lot of types of deviated septums, but in general, when the septum is deviated, it's either going to be corrected for functional reasons because it's blocking the airflow, or aesthetic reasons where the deviated septum might be causing the nose to appear twisted. And of course, both functional and aesthetic factors can play into it, and usually they are intertwined. So the question about whether or not surgery is safe and whether or not it will heal, we have to sort of look back to see what happens when people fracture their bones or they have orthognathic surgery. We know from those situations that the bone will heal if it's treated properly. So I don't think it's unsafe to have a deviated septum repair. It usually involves removing some of the bone or cartilages that's blocking the air passage or straightening out the cartilage. And so in the question that was posted, it was the questioner indicated that their surgeon was uncomfortable, and I could understand that because it's a pretty rare disorder for somebody to come into an ENT office with OI and have this particular problem. So what the patient may request is that the surgeon speak to someone at a university setting or get some advice from someone else who has treated patients with OI, because I think that if the septum is deviated and causing breathing problems, it should be fixed, because if there's airway obstruction and breathing is uncomfortable, that could lead to other medical conditions. So that's something that can be addressed and should be addressed.
Thanks so much, Dr. Napoli. So another topic of questions that came up pretty frequently in the chat was on the topic of teeth whitening. Are there any specific considerations that should be taken into account for individuals with OI who are interested in teeth whitening?
So I'm going to probably defer that question to Dr. Ricker and Retrouvey because they're far more experienced in that component of dentistry.
I think this is one of those that comes up every year. And Dr. Retrouvey, in my experience, commercial tooth whitening products may work. I don't know for sure for any given case. I think a great way to try it is with the cheapest over-the-counter options like Crest white strips and all those things. In the patient pool that we saw in residency at UNC, it wasn't the most effective over time. Things to keep in mind are that if you've had fillings in those front teeth, those will not whiten alongside your teeth. So if they had a perfect match between your filling and your tooth, and now you lighten the tooth up, you'll be able to see the filling from a mile away. The other option is what we used to do for folks that had severe aesthetic concerns was composite veneers, where you take a filling material and smear it across the front of the tooth if you had the kind of tooth that you could glue them predictably to, which wasn't always the case. But often even those were problematic in that they were too transparent and you would end up just making a lump of material on there that was not super appealing. For adults that are finished developing, I would think that, again, if your teeth are the kind of that can predictably hold on to some veneers, those might be your best aesthetic finishes, assuming that your bite is right and everything else.
You're right. I think the whitening material whitens teeth that do not have OI. So I would think that I would think that DI may not react as well as you think to enamel bleaching, because the dentin is not going to be effective. Right. Enamel is translucent, so not sure. There's no study on that. It would be kind of nice to try, but I've never seen a study on that. But it's a good question.
Thanks so much, Dr. Retrouvey. We do have time for one final question. And Dr. Retrouvey, I think this will be a good one for you to speak to. I know we are still learning more about aligners, specifically for individuals with OI. Someone posed a question in the chat about aligners being used to treat TMJ issues. Have you read anything about that or noticed anything about that?
Well, yes, there is a joke. I'm going to make a joke. I'm going to try anyways. Give it a shot. You know, you go to the orthodontist and you have no problems. You have TMJ problems. And the orthodontist will tell you, you need orthodontics to solve your TMJ problems. Then you go to the orthodontist and you have TMJ. Oh, that's because you had orthodontics. So the problem we have in the scientific reasons are very obscure. TMJ is a very specific, individualized problem. You can have bruxism, you can have arthrosis, you can have a lot of things. So TMJ is a massive amount of symptoms. And again, Dr. Napoli could talk to you about that. You know, you can have condylar resorptions, all sorts of problems. You can have the disc, which is in the condyles. So saying that Invisalign or aligners will treat TMJ it may be good in some situations, but you cannot treat every single TMJ patient with Invisalign because there is very little correlation between Invisalign and TMJ cure. So that's what I would say. I had patients that got better with Invisalign TMJ wise, and some we got worse. And I don't know why at the moment. So that would be my answer, but it's a great one. And again, be careful, but people will cure everything with one. You know, when everything is a nail and we have a hammer, everything is a nail. So be careful, get a better diagnosis from an old facial pain specialist, and make sure that your TMJ will have some chances to be cured with Invisalign. That's all I would say.
Awesome. Thank you so much, Dr. Retrouvey, Dr. Ricker, Dr. Napoli, and everyone with your amazing questions. The session has come to a close, but we do have a quick poll that we would like for you all to answer. It should be appearing on your screen now. And we just want to know, what language did you listen to this session in? Please feel free to complete that, and I'll leave it open for a bit before we close out this session. But I want to thank you all so much for your amazing questions. It's very important to ask questions during these sessions because that's what the sessions are for. And you may ask a question that another community member may have, and we can all gain a wealth of knowledge. So I want to thank you all so very much. And I also like to thank our amazing dental panel again. And thank you all so very much. I'll leave up the poll for a bit, and then I will close in about 1 minute. So thank you.